So what about the other end? Here we have a retroflex picture, and then I always take two pictures, David, another one. And there's a little polyp at the bottom, maybe one just next to the scope there, right at the top. And a lot of people, after doing a retroflexion, will just pull the scope out. And I have been guilty of that myself, but fortunately on this occasion I didn't. Next slide, please. Next thing. And there was this little thing sitting there. Next slide. And then when I looked a bit more carefully, this lesion was hiding behind the scope. Now, these I guarantee are the same patient. It would have been so easy to miss that lesion forward. And this little lesion, you might say, oh, well, that's not a very important lesion. Not all polyps end up cancers. Next slide, please. What about this little baby here? Doesn't look too terrible, does it? But for some reason, this wasn't in my hospital, but for some reason, this lesion wasn't removed. They were planning another colonoscopy. And of course, that wasn't done. And then next slide, 3 years later, this guy's only 57 by this point. He's got this cancer, which I found when he came for rectal bleeding. And this chap's ended up having his rectum removed. He's 57. And 3 years previously, he just needed that little polyp removing. So don't believe these little polyps aren't important. They are important. Next slide, please. Now, we have other places where we miss stuff, and I'm going to show you an example at the moment of me missing something in the hepatic flexure. But you really need to take special care in these areas. Next slide. What can you do? Well, you can roll the patient. You can use right colon retroflexion, which John's going to show you, distension, double pass, and tip attachments for all things that we're going to cover in a little while. Next slide, please. So what are my favorite positions? Now, you should take a screenshot of this. This is terribly important. There's been several randomized controlled trials and now meta-analysis of the benefit of turning the patient on withdrawal. I know some of you will be using propofol, and this won't be very easy, but I put it to you, why don't you stop the propofol when you've got to the cecum? You don't need the propofol on the way back. The patient could wake up, and then you could turn the patient on the way back. And use gravity to distend the colon with gas. And John's going to show this again beautifully later, and let the fluid drain away. Next slide, please. And get your assistants to watch as well. And just a few days ago, I must confess I got slightly irritated when one of my nurses found a lesion which I'd missed. And but then I thought, this is ridiculous. I should be having the opposite reaction. And again, this morning, one of the nurses saw a little polyp in the rectum, just a fraction before I did. And I congratulated on that and made her feel really, really good. We had a bit of a laugh about it. Next slide, please. Now, one of my colleagues, who is like a brilliant colonoscopy, missed this cancer. And I'd say, well, how can you miss this thing? And what he'd been doing was taking out a big lesion in the ascending colon. It took half an hour or so, filled up a Roth neck and came back. And he didn't see this thing, and the patient came back for a site check 6 months later, and he was totally and utterly horrified to see this. So even the best people can miss, and the point here is that he was busy, distracted, he had low expectations. You know, there are lots of reasons why he didn't see this thing. Next slide. So I'm going to show you my patient. So I'm hanging my dirty washing out here. So this chap had a rectal cancer, which I diagnosed, and lots of polyps. He came back after his resection. I did the colonoscopy, found 15 polyps. Now at 77, we wouldn't necessarily have had to offer him another surveillance, but I thought he was in a very high risk category with lots of polyps and a cancer, very high risk. So I said, come back in a year. And of course, COVID happened and he came back in 2 years. And basically, when he came back, there was a little cancer in the hepatic flexure. This is a cancer that might have been diagnosed earlier at the recommended interval, but actually I put my hand on my heart and said, this is a cancer that should have been prevented by the endoscopist, which was me, had I not missed the lesion. So how did I miss the lesion? Next slide, please. So if I remember, there were lots of polyps. There were 6 polyps. There's a bit of a lot of dye in this chap's colon. It's removing a lot of polyps. And I must have not looked at the hepatic flexure properly. Next slide, because when I came back to do surveillance, I was completely horrified to see this. Now, the guy's fine. He had a right hemicolectomy. Did he need that cancer? Probably not. So it's very easy to miss stuff. Next slide. In our audit of 1,724 PCRCs, we asked the question, were there procedural difficulties? And any difficulty, 27%. And this just...
I'm just going to skip ahead a little bit.
Centimeter time when you're in talk.
So one of the other values of these webinars is, again, the deconstruction or the discussion that happens afterwards. So one of the discussions in this webinar was regards to retroflexion in the right colon. And I know we've all been traditionally scared of retroflexing in the right colon, and I think there is some truth to that, and we should have some certain degree of fear to it. But once you're able to do it, and once you've adapted to it, it really is an invaluable tool. It helps you pick up more adenomas. There was one study from South America which showed the number needed to treat or number needed to retroflex to pick up one extra adenoma was just 9. The other thing is, if you are doing any sort of therapy, it's an invaluable tool to do therapy, because sometimes you just can't get the back end of a polyp and you just really need retroflexion to get there. So this is just a discussion at the end with regards to retroflexion in colon.
And I think this all increases your efficiency of the withdrawal.
Yeah, I think there's 2 more things I'd like to discuss about this before we move on to the final part about AI for the last 15, 20 minutes. One is retroflexion. So if I reshare the video, I'm going to share a poll here and ask how often people are using retroflexion. But let me just share the video again. So you had trouble retroflexing here, John, right? I mean, you had trouble, and can you explain to us why that is before we get into the rest of this? Because you can see really the view that you got was not optimal, was it? This is about the best view that I saw on the video in retroflexion. So why was that?
So I would have predicted this, David. So a long redundant colon on the way in, and I'm using a floppy scope. And therefore, when you insert and you retrovert, you need really the force along the longitudinal shaft of the instrument to turn the instrument round at the end. So you acutely angle at the tip and you push the scope in. And therefore, you need the force to be transmitted along the longitudinal shaft of the instrument. And whilst the instrument looks relatively straight there, there's an awful lot of movement and give, because sigmoid's very mobile, splenic fetor is very mobile, anterior component of the transverse very mobile. And when you push in, a lot of that forward force was not being transmitted to the tip, and therefore wouldn't give you a good turn. In addition to that, the ascending colon is relatively short, and therefore the tip tends to go medially into the cecal pole, and then just pushes the cecum medial and doesn't actually rotate off the ascending. And you look at the imager there, the ascending colon here is really short. So I think for all of those reasons, I would have predicted this would have been difficult. It was possible. It wasn't very elegant.
And how many percent of patients, John, do you think that this occurs in? Like, because I see in this poll, like, let's end the poll and let's share the results. So the results say that the majority of people are not doing right colon retroflexion. So, I mean, let's go around the faculty. Maybe let's ask, can a couple of the Ghent people show your video and unmute so that we can get some views of trainees on here? But why do we think as a faculty that people are not doing it? And then we'll ask the others. Lobby, you want to start? Why are people not doing right colon retroflexion? The majority of people are not doing it.
Yeah, I think the major reason will be that they're not used to doing it and scared to doing it. I think 2 things you have to get used to. You have to make it a habit, and you can do it very safely if you never force your scope to do it, and always do gentle movement, and I think it will always work. But I think those are the main reasons.
Sander, are you there? Can you talk to us? Can we hear you? Why are people not doing right colon retroflexion?
I think indeed the majority of people are scared to do retroflexion to the right colon because it's being perceived as difficult. Maybe not being trained as much as the other techniques in colonoscopy, because a lot of trainers, the ones that trained me prior to you, were not routinely demonstrating retroflexion in the right colon. So I think that is one of the more important reasons.
Jan, why are people not doing retroflexion in the right colon?
I completely agree with Sander, but I think I can speak for the center I'm from, that a lot of people just never thought of doing it and were never taught to do it, so they just never did it. And I saw it from you, and I've started doing it from then on. But there are not other people in my center that are doing it for now. So I think it's just not well known, and people are scared of doing it because they don't know it that well. And established colonoscopists don't always tend to change that easily because it takes a little bit more time maybe to do it. So yeah, I think those are the biggest hurdles that I saw.
Yeah, I agree with that. And Vikash, welcome to the call. Can you give some reassurance to people who are scared of doing right colon retroflexion, some words of wisdom as to how they can get over their fear and start doing it? Because I think we all know, and all the faculty would support the fact that right colon retroflexion picks up a lot of lesions and makes you very secure in your assessment of the ascending colon.
Yeah, thanks, David and team. Well, firstly, I think ergonomics has a lot to do with it as well. You got to be able to turn the up, down, and the left, right wheels fully down with one hand. And as soon as you're taking your hand off the shaft to turn the wheels down, that's when it adds a little bit of fear and a bit of complexity. So ergonomics play a big role. And then, I was well taught this by you. The key is to simply not push and pull, and rather to torque the scope and let the scope kind of flip itself over. So, and as soon as if you're feeling any resistance or seeing major blanching, then yeah, certainly stop. But appreciate the cecum that's medially lying and know that you may need to retroflex before that cecal pole, and the cecum which is fairly straight, you can go straight into the cecum and retroflex. Yeah, I think the key again is torquing the scope and not pushing or pulling.
Not pushing, not pulling, not pushing hard. John, what percentage then is like this? What percentage of, because people out there, they're worried about doing, okay, we've had some now.
I'm just going to stop it there. Yeah, apologies. The one thing I actually forgot to show you, and I just want to highlight now before we move on to some of the other content, is the online scores. And this is another value of the website. So in one of the presentations there, you heard mention of the cecal visualization score. And if you go into the online scores tab, that's easily available for you. And you can actually just click it and ensure that you have actually visualized the cecum. The other score that I personally find very, very, very helpful, and I use this in my practice as well, I often get referred these complex polyps. Sometimes you're standing there and you're looking at the polyp and you're thinking, should I attempt this today? Should I do an EMR? Should I do an ASD? And this is a very valuable tool to help you make the decision, because it gives you the risk, an actual percentage risk of submucosal invasive cancer. And it's based on data from mostly coming out of Sydney, but from data as well. So essentially, you see a big lesion and you want to work out the risk of whether it's got overt cancer or covert cancer. So let's just take the example of covert cancer. So this is essentially cancer you can't see. There's no demarcated area. And this is cancer that's usually buried underneath a big nodule. So you go into the rectum, you find a big 60 millimeter lesion. It's located in the rectosigmoid, which confers a higher risk. It has some non-granular components to it, and that confers a higher risk of covert cancer as well. And it has a nodular component, so it's a 2A1S lesion. And then you calculate the risk to be 18.9%. And based on that, you can make quite an informed decision. I often, if I have someone in the room with me while I'm scoping, I just get them to pull out their phone and I just plug in these numbers into the calculator. And I use it to make a risk stratification calculation. And basically, there is no ideal to it because we don't know what actually confers high risk or low risk, but it's based on the patient. So for example, you have a 90-year-old patient who's on anticoagulation, is very comorbid, 20% risk of cancer doing something piecemeal may be acceptable to that patient. But you have a 35-year-old patient doing a piecemeal procedure when you have a risk of 20% of cancer is not ideal. And the issue why you don't want to do piecemeal there is because when you do a piecemeal resection, the pathologist simply can't assess the margins. You have cautery on the end of the margins, and they can't put together pieces and tell you if your lateral or your deep margin is clear. Then you get malignancy coming back in your resections polyp, and you just don't know what to do with it because you're not sure how deep it is, you're not sure if margins are involved, and you just don't know how to advise your patient. So the other valuable tool, and this is where we need to start moving towards. So the issue in South Africa is you fill in your logbook with 200 colonoscopies, and then you are released from the CMSA, and you can go out and do colonoscopy. But just because you have 200 names in your book doesn't mean you can do colonoscopy. And just because you've done 200 colonoscopies or filled in 200 names doesn't mean you can do polypectomy. So this is a tool that David and the team at GIEQs developed to assess competency in polypectomy. It's called the GPAT score, the Global Polypectomy Assessment Tool. And it goes through various components of polypectomy. And it's essentially at the end, once you've done 30 polypectomies, it validates you. And it validates you according to how complex polypectomy you can do. So there's a well-validated score called the SMSA score. An SMSA 1 polyp being quite easy, and SMSA 4 polyp being hard, and an SMSA 4 plus polyp being the hardest type of polyp. So you get validated as an SMSA 2 polypectomist or an SMSA 3 polypectomist. And that's, outcome-based assessments. It's not just names in the logbook. And you can see it encompasses quite a number of techniques. And these techniques are all covered in many, many of these webinars. So how good is your tip control? Very poor, average. Do you fully appreciate the lesion? Did you get the lesion down to 6 o'clock? Did you use the right technique? Did you use en bloc? Did you use cold? Did you use hot? Did you use piecemeal? Did you inject in the right plane? So often you see people shove that injection needle in, inject, and you just don't see any lift. That's because all the injectate is going into the peritoneum. They then pull back and you start seeing the plane. So the idea is to get that plane on the first go. So did you get that injection in the right plane? Did you do it dynamically? Did it actually improve access to the lesion? Did you choose the right size of snare? Did you get the lesion down to 6 o'clock? When you close the snare, did you actually get tissue capture, or did your snare just slide off the surface? Because that's how you leave pieces of polyp behind, and that's how you get recurrence. Did you visualize the V of the snare? Were there any residual islands? Did you perform safety checks prior to performing hot snare? And then did you look at the defect? Did you look at the defect for residual polyp? Did you thermally ablate the margin? Did you look at the defect for any deep mural injury? So this is another very, very valuable tool which is available here on the online scores. I'm just going to take you through a last few videos, which I think, and this is a webinar which was essentially hosted last week. And I think there was some brilliant content in this webinar and just really highlights the aspect of why we need to be performing high quality endoscopy and not just putting that scope down into D2 and whipping it out in 30 seconds. And this is essentially our value as endoscopists, and this is exactly where we want to come in. And these are, again, everyday real life cases. So I'll just take you through one very simple, or what we might think is a simple case, and just show you the complexities involved and the things we've never actually thought about with regards to what we think is simple cases.
Combination. Great. Okay, that's really important. So the next video that we have is more esophagus. I'll share it with you. Hopefully you can see it. So I'll let it play a bit. Maybe we can get some interaction from the audience, and I'm not going to pick, but I am going to pick from the Ghent crowd if no one is busy. So maybe you guys can be ready to jump in. But I mean, just look at that first image there. Is someone? What are you seeing there? I mean, it's not very clear. It's a little bit blurry. That's real life, I guess. It's a gastroesophageal junction. I'll give you that for free. What do you think? Someone jump in.
It has a bit of an inflamed aspect, a little bit of a distorted aspect.
So identify yourself. That is Dr. Xander Smeets of Ghent Hospital. Welcome. Yes, a bit of an inflamed aspect. I like that. And what is drawing your eye here? What is the problem? What's standing out to you?
Well, now at the 1 o'clock, you have like a tongue, if I may, of inflammation, and just below that, there seems to be a little bit of like a nodular aspect of the actual junction.
Okay, so this is our like looking from a far part. I totally agree with you. So there are folds here on the left-hand side, and then on the right-hand side, there are no folds, and this whole area is flattened out and much more red than the rest, right? So this jumps out at you. And then as we go a little closer to it, so we'll just see, it's We'll go a little faster than normal. So okay. So you can see that it's really definitely just above the top of the gastric folds. And as we pull back on it in white light, it's because we have a cap on. I think it's a little easier to image it. What's your first impression? Somebody else? I mean, is that something to worry about? Something not to worry about? And why? Do we have PTN maybe or Lynn? Or
Hi. Yes.
Hey.
Hi. So yeah, I do see some inflammation as well. It might be a little piece of a Barrett, I would say, at 1 o'clock.
Okay.
But because of the inflammation, I'm not so sure.
Ian, did you want to make a comment?
Yeah, I think that's columnar epithelium above the level of the gastric fold. So that's a piece of Barrett's.
Right. So we've got a couple of votes for Barrett's and a discussion about whether this is Barrett's or not. What are you thinking, Matt, looking at this from here? Is that Barrett's?
It's at the top of the gastric folds and it's no more than 5 millimeters. So it's not Barrett's.
Yeah.
I think the other thing that really jumps out here is you can see the inflamed mucosa at the bottom of that area, but there's usually with inflammatory tissue, you will maintain some form of regular architecture. And this isn't present at all. There's nothing. It's completely void of any architecture, which worries me.
Okay. Right. So what we want to do, as per the schema that we've already presented to you, is go closer to this. So this, and I make absolutely no apology for every one of these videos being with a very high definition scope, because we're trying to show you
Apologies, I just changed the picture quality.
What's achievable. Now, that doesn't mean that these views are achievable in everyday life, but I firmly believe that if you've seen with this degree of imaging, then you can take that back and transpose that back into your everyday practice. And we do have multiple videos on the site of less high resolution imaging, right? So Vikesh, you have got a comment before we go closer?
Hi, David. Yeah, thanks.
Welcome.
Yeah, I mean, my impression is that there's certainly some chronicity going there. You're getting the impression of fibrosis, perhaps some traction divertically forming there at the 2 o'clock area. It's hard to say what the orientation of the scope is, but on first impression, it looks like a 1 to 5 clock face distribution. We'll have to go into the stomach to confirm that.
Nice comment. Let's have a look at the orientation. Sneak into the stomach here. So you can probably say that's the 3 o'clock and that's the 9 o'clock, probably. So if we come back, still the 3 o'clock is it's difficult. The endoscopist is bad, but indeed that is probably 3 o'clock, as you rightly say. And what is the relevance of what you're saying for those who maybe are not certain of the relevance of the 2 to 4, 2 to 5 o'clock arc?
So it's the area where the acid's going to spend most of its time, and it's the area where you're going to find most of your Barrett's cancers at the same time. So, yeah.
It absolutely is. And there's also data to support that is the area. And we've already said this is not Barrett's, but if this was a Barrett's, then that will be the place that you're really looking for the money in terms of cancer. Did you have another comment?
Yeah, so my impression is that this is quite severe reflux, essentially, but that certainly warrants a closer look.
So we are a little bit concerned. We've got someone who's on the side of reflux. We've got someone who's on the side of maybe a little bit something more worrying, but anyway. So now let's go closer. So we switch from white light to narrow band imaging, right? This is on the edge of that area. So this is imaging here, right? The next screenshot image is here. So what we have here is probably some scarring. And what we have here is these little capillary things. So I use the word capillary things because the term for them is intrapapillary capillary loops. And it's really quite an annoying, I think, a Japanese coined term, which is very difficult to pronounce and say. I practiced it a lot before this webinar. So they are the small capillaries of the squamous epithelium. And you can see there's a nice line here between normal looking ones, and we'll go in a minute through a little rapid tour of the evidence of what these things, structures and classifications look like. And on the left, where it's not at all normal. So this is the area, and let's just go back to the overview so we can orientate ourselves. We're looking at this. So this area, Matt, I think is what you said was where there's really no structure at all. I think you said that, right? You had this inflamed zone here. Is that fair enough, characterizing, rephrasing what you said?
Yes, yes. So this is either severe inflammation where you've lost architecture and you've got some regenerative mucosa below it, and you've got other features of reflux esophagitis, or it's neoplastic, one of the two. So
just to pick you up on what you just said there, Matt, you've got other features of reflux esophagitis. That's a really important comment, and you see it. Is that what you mean here on the bottom in the kind of in the 7 o'clock?
Yes, yeah, well, a 3 or 4 millimeter mucosal break.
Yeah, that's very important, and thanks for pointing that out. So then as we go closer, we are into this territory. So this area here is what Matt was talking about, regenerative tissue. And then you have a whole area here, which has got a little bit of blood, a little bit of bruising. But then we can just skip through until we get a nice, so this is underwater with a cap. If you want to achieve this level of imaging, the patient must be intubated and you must have a cap on with underwater imaging. So we have moved from the pattern that you saw before, which was this one, this very, very, very small, very tiny vessels, quite sparse, all going in the same direction, to this, where you have many, many more of those vessels present. I think we can argue that they are relatively regular. They all point in the same direction and they're not particularly dilated. So for me, when I was imaging this was severe inflammation. And we will go through now multiple examples of the difference between severe inflammation, and that's what Matt said and what Vikesh said, and cancer. And I think it's fair to say, and please correct me if I'm again paraphrasing you, Matt, but when you look at it up here, it becomes more clear to those who spend a lot of time doing it, and hopefully after this webinar, you watching. But from here, it's not really possible to tell between the two, is it? It's not possible to tell because you haven't analyzed the microstructure. That's what you were saying, right? That you're worried about it, you're concerned about it. It could be something, or it could be inflammation, and you need to look closer. Is that fair to say what you were saying when you just seen the white light images?
Yeah, absolutely. I suppose from here you can see there is a slight demarcation line between the more distal mucosa and this area, but again, you can't tell the difference between neoplasia and inflammation.
And do you agree, Matt, and the others, please comment as well. Do you agree with my assessment of these IPCLs or intrapapillary capillary loops?
If I come in, David, just say for the people watching, when you're flicking between the long distance view and the near focus view, the long distance view is in white light and this is in NBI.
Right.
So there's a difference in modality. I agree with you in your assessment of the capillary loops, which is just the underlying vascular structure which is on the surface of the mucosa. That's what David is referring to. And I think I made this point the other day, David, where you've got a lot of background noise here, and a lot of background noise like this with narrow band on only either means inflammation, or you also see it at the extreme end of pathology where you get malignancy and you get hemorrhaging and inflammation within the thing. And when you go through, and you'll see some examples here where you've got areas of dysplasia, you don't have this background noise on NBI or other modalities which emphasize the underlying vascular structure.
Matt, you want to make a comment?
I was just going to say that most of these you've already commented on. Most of these vessels are of equal caliber and are fairly organized, which is very much against neoplasia. But again, here it's about spotting, describing, and taking a targeted biopsy from the area that you suspect to be most abnormal.
So that's really important. I'm so glad you just said that. So a targeted biopsy, I'll come back to you in a second, ask you what you mean by that. But we have, I think we can all agree that in the upper GI tract, we are biopsying everything for a diagnosis. Is that fair enough for the faculty? The majority of things unlike the colon, we have loads of material and loads of evidence that if you biopsy, you can disrupt, you can make it more difficult to resect. In the upper GI, please biopsy. I think that's a fair enough comment. And Matt, what do you mean by a targeted biopsy?
Because the focus of abnormality within the upper GI tract can be really quite small, you don't want to start taking blind biopsies. The first biopsy you take will bloody your field.
Right.
And I suppose there are two aspects of targeted biopsies. The first are if you're surveying a Barrett segment or an area of atrophy, you need to try and increase your yield, not by taking blind biopsies, but by targeting an area of pathology that you think is most severe, so the highest grade. And once you have targeted any abnormality, you can then go on and take random biopsies or Seattle protocol biopsies. So, but most pathology, your pathological yield from targeted biopsies is far greater than level or random biopsies.
Okay, and I mean, it's relatively obvious in this case. We'll come to less obvious ones, but in this case, you want a biopsy here, right? I mean, that's...
You do, and you don't, I know the recommendations are 6 biopsies, but that's really where you're taking, you need a single good biopsy. That's all you need in the right.
So yeah, the point of showing this video is not to make everyone expert endoscopists or advanced endoscopists or interventional endoscopists, but to just show that the level of thought and the level of detail that goes into endoscopy is, just not where we're just not where we need to be. And just to highlight that simple things that we think is just reflux or simple things, there's a lot more to it. And I think this was well illustrated by, comments that were made in the group previously, just with regards to, I was just asking a question about how many people handle the snare themselves when they're closing it. And one of the comments was, we never knew these things. And that's what I'm trying to highlight, is that there's a lot more to endoscopy and we need to be thinking about it all of the time. And the level of detail to it, it's not just about putting the scope down and pulling the scope out, looking for that advanced cancer when the patient is already has this grade 4 dysphagia and you're basically just doing a palliative stent. That's not where our value as endoscopists come in, but picking up these early things. And these are the discussions that we need to start having. And I say this because I know these discussions aren't the discussions that are ever had, and we don't really get taught these things. But I think these are the conversations that we need to start initiating and moving forward as a whole in terms of quality and endoscopy. So I'm just going to play one last example, and I think
we got 1 minute, Vikesh.
Yes.
So to Matt's point, withdrawing in MBI, information here, and then you turn my audio commentary off. So here we go. We're just withdrawing the scope, normal speed. Okay. We're out. See anything? Anybody?
So this is just highlighting the value of actually withdrawing in MBI.
Even with my glasses on, I couldn't see anything.
Do it again. Do we see anything? So I mean, quick. Yeah, it's trying to make a point, I guess. But I mean, this is real world. No, this is what people are doing.
Oh.
There's something there at about 5 o'clock, David.
It's taking you 2 goes to see that, but okay, let's go back to it. Here, is it this you were talking about?
It's not, yeah.
Okay. So let's do it again. But let's do it in MBI. So to Matt's exact point of, oh yeah, I've given the game away there. To Matt's exact point of withdrawing MBI. So I don't think it's unobvious that that's much clearer in MBI, right? I mean, Lubka, anybody? I mean, it's a night and day. How much more clear this withdrawal is, even if you do it really quickly. Let's do it really quickly. Okay, I can still see it versus the white light one. Still very difficult to see that, isn't it? I mean, it's
just to show you what it actually was and how you can actually assess quite well squamous lesions in terms of depth of invasion and what's endoscopically resectable.
It's above 20%.
I think we had a poll on that, actually. Let me just see if that's true. It's actually question, although you can see the questions here. Did we do one of the things on the poll? Yeah, it's actually what sort of, is that totally regular? A bit like the one we saw before, is that, you know, regularly irregular, or is it completely disordered?
You
Want me to
asking?
jump in, David?
Yeah, please.
I'm jumping in, and just macroscopically, I agree with Matt. So this is not flat. Between sort of 1 o'clock and 3 o'clock, there's a patch of what was almost normal, and then you get into the denser, deeper pigmentation here. You've lost the ulcer slough across the top. You've got very fat, dilated vessels coming down from that, almost like a shelf, and then vessels coming down. You've got a porosity area right in the center of the screen, which has virtually got nothing in it at all. And then down at the bottom, the very bottom at 6 o'clock, you've got a different type of vessel again, where there's dilatation. There's maybe a couple of loops there. So you've got every type of loop going on in this lesion. This is a cancer.
This is definitely a cancer, but the question is, how deeply does it invade? Do you see any of those very, very nasty loops in there, Matt, the B3 type loops that we talked about just before?
So in that paper, the gamma paper, the B3s were 3 times the other capillaries, and you can argue just where your cursor is, no, go up there. Yeah. So this is, and if you looked at the peristalsis, this is a rigid lesion. It's invading probably through to the muscularis propria.
Vikesh, I think we should.
It does move, doesn't it, on and on?
Yeah, so just to wrap up, I mean, they were talking about the Japanese endoscopic classification of intrapapillary capillary loops, and that gives a good idea about depth, and those big dilated vessels tell you it's going deeper down, and that's completely not for endoscopic removal. When you see these B2 vessels, which are just unfolded and no more corkscrew light, that's going into the muscularis mucosa, or the MM3 layer, possibly SM1, and that's where you can attempt endoscopic removal by ESD. But again, just to highlight the sort of discussions that we need to be having as a group and as endoscopists in South Africa, and the direction we need to be heading towards to improve quality.
And Vikesh, look, it's one thing to be wanting and be able to transmit knowledge, but look at the unique way in which this is done. It's not didactic. It's not a monotone, voice in the background, with people with an attention span of 5 seconds, which I have. I mean, I'm glued to these discussions because they're bantering. You've got different experts. I don't think we need to sell this anymore. It really is the go-to platform. And if I can just make some comments, congratulations on being elected to the scientific board of GIEQs, Vikesh. I think that's a great honor. And I think you'll all agree with me that, I think there's no better ambassador than to resurrect the foundation's in endoscopy interest group, which we did have many years ago, which has kind of been dormant for a while. And so it's a pleasure to announce our first meeting in June, first Saturday of June. We've given it to Vikesh to put together. And so we'll be having a meeting in Johannesburg, face-to-face, on a Saturday morning, and it will be live streamed. So we'll send out flyers advertising that date. And then finally, when we were alerted to this by Vikesh, we got very excited, and we bought 50 registrations prior to the GIEQs Symposium in November, was it last year? September, November? September. Yeah. So we really directed it to the fellows. There was good uptake. It not only allowed you to take part in the symposium, but it gave you a year access to the GIEQs platform for all the educational talks and programs that they have. So we've got 20 registrations that haven't been taken up. They're going to give you, it's going to allow you another 6 months access to the platform. And we've got, because we bought them at a reduced rate because they were directed for fellows, we had to get permission from David. And Vikesh, I believe you've got permission. So we're able to advertise 20 registrations to those that are interested. It will come on a first come, first served basis. So I think, Vikesh, if they can contact you and perhaps if we can just make a note of the names, and then we'll help you with the administration on how to make these available. Any final comments, Vikesh?
No, yeah, I just I think it's an excellent start, the endoscopy interest group. And I mean, the one common denominator between all of us, medical, surgical, peds, is everyone's doing endoscopy. And yet, I think it's been taken a bit of a back seat, in our training. And these conversations aren't the conversations that have been being had. And I think we need to highlight endoscopy a bit more. Of course, I do have my biases, but that's where we need to move in terms of quality. And hopefully the interest group is the first of many and helps us propel in the right direction.
So thanks, Vikesh. I mean, excellent, really start. And thank you for really putting such momentum and excitement into endoscopy, certainly in Johannesburg, since you arrived towards the end of last year. I mean, he runs a WhatsApp group, and every day there's bantering and excitement and cases and discussion, and that's just using a WhatsApp platform. So imagine what we can do. So it remains for me to thank David and GIEQs and all the speakers and Vikesh, and to our iEcho platform, iEcho, our local iEcho, and also India team, to the sponsors. And this talk will be posted on the GastroFoundation website. So if you want to have a rerun of it. And next week, the session will be devoted to pediatric gastroenterology. So from Johannesburg, for those who are in South Africa, enjoy the holiday tomorrow and enjoy the rest of the evening. And Vikesh, thank you again once for a wonderful introduction to GIEQs.
Thanks,
Goodbye,
Prof.
everyone.